Okay. All right, so we're going to start. Okay. Egg freezing 101. So the basic concept of egg freezing, what is egg freezing? Why do we do egg freezing? Right. We know that women there's a rate limiting step in fertility. Basically, fertility declines as a woman gets older. Right. A lot of people have heard the phrase biological clock ticking. Right. That refers to decline in fertility as a woman gets older. So after about like 28, 29 years old, fertility goes down. Okay, and we know that because women, as they get older, it becomes more difficult to get pregnant. So we know that because when someone does get pregnant and they're trying, it usually takes longer compared to if someone was younger. And the chance that it doesn't happen and they're not pregnant after like a year of trying increases as you get older as well. Another way we know that reproduction is not as efficient as you get older is that even when someone does get pregnant, the risk for miscarriage is higher. All right. Um, so when someone's in their 20s and they were to get, would have a positive pregnancy test, the risk for miscarriage is low. It's about 10%, but it gradually increases after about, 30 years old. By the time someone's 40 years old, the risk for miscarriage is about 40%. Someone who's 45 years old, when they take a pregnancy test and it's positive, the risk for pregnancy loss is about like 70, 80%. Okay. Now, if someone does not miscarry, the risk for aneuploidy, like Down syndrome, is a concern as you get older. That's why you've heard that women who are 35 or older, they're given the option of having some kind of prenatal genetic testing, whether it be an amniocentesis or CVS, check the chromosomes of the baby to see what, make sure it's not Down syndrome. That increases as you get older as well. So all those are related. You heard it from biological clock ticking, difficulty conceiving, decrease in egg quality, decrease in egg quantity, amniocentesis, Down syndrome. They're all related. Okay. So the biggest the main reason why people do egg freezing is kind of preserve fertility. Right? But it's important to understand what that means. All right. People think like, oh, I'm going to freeze my eggs because it's like an insurance. So it is an insurance, but you have to know what you're insuring. You're not insuring or guaranteeing that you're going to have a baby later on. What you're ensuring is that when you try to have a baby later on, when you're older, it's as if you were trying to get pregnant now. All right. Because someone can be trying to get pregnant now. There's no guarantee they'll get pregnant now. Right. But the chance of getting pregnant now is most likely going to be higher compared to like if someone's trying to get pregnant, say 3 years from now, or 5 years from now, or 10 years from now, or what have you. So that's the concept. It's basically to kind of preserve your chance for conceiving or fertility as if you were trying to get pregnant now, but you're going to do it later on because you're not ready. One's not ready to get pregnant now for one reason or another. Okay. So the concept basically that we'll talk about, like the first aspect of it is like egg quantity. So when a baby girl is born, whatever eggs are in her ovaries, that's it. They do not regenerate, they do not multiply. This is a contrast to like sperm. So, so that's why men, they can father children in their 30s, 40s, 50s, 60s, 70s, because sperm regenerates. Eggs, on the other hand, do not. So when the baby girl is born, whatever eggs are in her ovary, that's it. Over time, it gets used up, right? You ovulate every month, and once there are no more eggs, a woman's in menopause. And right, once you're in menopause, um, you know, unlikely to have any children naturally. Okay. So you can see in this graph over here is basically the number of eggs in the ovary. So you can see it actually peaks right before birth. It's usually about like 6 to 7 million, usually about 20 weeks of gestation. By the time someone's born, it's now but down to like 1 to 2 million. Okay. And over the period of time, you start ovulating in probably menarches are like age 10, 11 years old until someone's about, again, on average, maybe about 50 years old. So during that time, you ovulate probably about like, 400 eggs during your lifetime. So very important to understand. Say people do the math. They're like, well, if I got 1 to 2 million eggs at the time I'm born, and I'm only going like 400 months of like an ovulation between when I'm 10 years old and 50 years old. That I only use 400. Well, that's a lot of there was a million to begin with, I thought. Well, what happens that when each month, even though you just ovulate one egg most of the time, you use up a couple of hundred eggs each time you do it. So what happens is a dominant follicle effect. So you recruit hundreds of follicles, but the body knows that the human body is not meant to carry a litter. We're not like cats or dogs where litter is the norm. For obvious reasons, our uterus is not made that way, and so it only really wants to have a singleton pregnancy can maximize the health of a delivery. So what happens is once a dominant follicle emerges, it suppresses the other eggs. And the other eggs stop growing and they are discarded or reabsorbed by the body, and then one egg gets ovulated. That's why most spontaneous pregnancies is usually a singleton pregnancy. Every once in a while, there may be a couple of follicles that develop, and that's why twins are also, can happen spontaneously as well. Okay. But the point is, each month, a couple hundreds of eggs go away, and over time, once they're all used up, there's no more eggs. And there's a survival advantage for, the body's smart. So they know that the best eggs come out when someone's younger, because from an evolutionary standpoint, it makes sense to be most fertile when someone's in their teens and in their early 20s. Because 10,000 years ago, where our lifespan was a lot less, that you kind of went for the survival, evolution, the survival of the species. You want there's a survival advantage to have the best eggs, the best quality eggs come out when someone's like younger. Okay. So unfortunately, in 2024, our bodies haven't caught up or haven't adjusted to current civilization, where now our lifespan is probably three times, 2 to 3 times more than it was like 10,000 years ago. Okay. So, and then even just from like one generation to the next, just like one generation ago, the average, age of a woman starting their families is usually their mid 20s. Nowadays, in the last like 20 years or so, things have changed. So society has changed. A lot of women enter the workforce, education. Even couples who are getting married, they've delayed childbearing, for a few years. Getting their careers stabilized or finances in order. So the average, a couple starting a family is several years later, just compared to like one generation ago. And as we talked about before, fertility goes down as a woman gets older. Okay. Right. Um, so that what we talked about was the quantity, right? We talked about, how many eggs and so forth. But there's also, like I said, there's also a decrease in quality of the eggs. And like I mentioned before, we know that because when a woman gets pregnant, okay, one, it takes longer to get pregnant, usually more longer to conceive. And when someone does conceive, the risk for miscarriage is higher. Okay. And you can see here's the risk for miscarriage as a woman gets older, and it has to do with the number of, and it correlates with the abnormal eggs. And again, like the reason why people miscarry is because, again, if it's not a normal pregnancy, it's got an extra chromosome, it's lacking a chromosome, like Turner syndrome, or an extra chromosome like Down syndrome, or a whole chromosome, a whole extra set of chromosomes, or it's like triploidy. Again, these are abnormal embryos, and most of them, since they're not viable, will result in pregnancy loss. Okay, so two reasons why it becomes more difficult to get pregnant: quantity and quality. So egg quality, which is like chromosomes of the egg, and quantity in terms like even when you're doing IVF to overcome, to take advantage of the of IVF, which is to kind of get, several eggs. More eggs you get, the better chances of having a normal embryo. Um, is compromised as well as a woman gets older. So we can tell from a quantity standpoint, how can we tell how good one's ovarian reserve is? There are different ways to check someone's ovarian reserve. So again, it's a predictive factor on one, like how active their ovaries are, how they're going to respond to the medication if someone's going through IVF. For example, like one variable that can kind of guesstimate one's ovarian reserve is age, and you can saw from the graph before, pictured basically as a woman gets older, there's a decrease in number of eggs. You can do an ultrasound and give us an antral follicular count. So here's a depiction of an ultrasound picture of an ovary. See those black circles over there, and each of these are follicles. You can't see the eggs. Remember, this is an ultrasound. Eggs are very small, microscopic, so you're not really seeing the eggs. But when you inside these follicles, that's where the eggs are. So you can see these multiple follicles or circles, depicted over here. Inside these follicles are the egg. The more follicles you have, the more active your ovaries are. So that's one way, another way besides age to kind of guesstimate or assess one's ovarian reserve. There's also some blood testing that can be done to kind of assess one's ovarian reserve. There's an AMH or called anti-Müllerian hormone. So when you see your physician, they'll address that as well. Again, it's this test the ovarian reserve, egg quantity. It does not test egg quality. Okay, egg quality is more based on age. Okay. So this is kind of how it works in the body. Just kind of trying to simplify the picture. Basically, it works hand in hand. It's all it's all interrelated. The brain, the pituitary gland, secreted its hormones to stimulate the ovaries to release eggs. When the eggs are released, it transports down the fallopian tubes, and if there's sperm present at the time, fertilization takes place and implants in the uterus. So it involves several organs of the body. It's not just the ovary, it's not just the uterus. It also involves the brain. So a lot of things have to go right. If any part of the system is gone awry or not normal, then it can affect fertility. All right, if there's some kind of pituitary tumor, that will affect it. If someone has surgery because their ovaries had ovarian cysts, they had endometriosis, they had ovarian cysts, it was taken out, that can decrease your ovarian reserve. If someone's got abnormal uterine, some kind of congenital abnormal uterine issues like a fibroid, or their surgery, the tubes are blocked, and that can affect that part as well. So that's why when someone has difficulty conceiving, it deserves a complete workup. Just checking the tubes, checking the uterus, checking the ovaries, and just as important. A lot of times people don't think is as important is to check the sperm of the partner. A lot of times women will come in and say, "Well, I want to just check my fertility because we've been trying for 2 years or 1 year." And say, "Okay, then we'll do a semen analysis." Oh, my husband or my partner doesn't want to get checked out. Well, it's kind of hard to do that when the sperm is half of what we need to have a successful pregnancy. Okay. So egg freezing basically is similar to IVF. All right. The only difference with IVF stands for in vitro fertilization. So the big difference is with egg freezing, the eggs are not fertilized. Once we get the eggs, we freeze them. With IVF, when someone's trying to get pregnant, once you get the eggs, we do fertilize them, and then you can freeze them. So it's just different. The difference is what stage they're frozen at. But the beginning, the basic cycle is the same, where when someone usually gets their period either naturally or after, say, birth control pills, to kind of more better predict or schedule your cycle. Um, you start the injections. They're called gonadotropins. The daily injection you take for about 10 to 12 days on average. The purpose of those injections is to stimulate the ovaries to make several eggs. Remember, I said before early on, you get a couple hundred of follicles or eggs to kind of grow, but in the body, once a dominant follicle emerges, it suppresses the other eggs, the other follicles. The goal of the injections is to kind of get more than one of those follicles to keep on growing. So the more the better. Ideally, several eggs to kind of several follicles to keep on growing. Okay. Usually, like I said, between 10 to 13 days of stimulation. After the last injection, once we know we got a good number, a good proportion of those follicles appear to be mature, you take one last injection called a trigger shot, HCG or what have you, and we harvest the eggs 2 days later. It's done under anesthesia. You're knocked out. It takes anywhere from depending on how many eggs there are, it can take anywhere from 5 to 20 minutes. Um, After the procedure is done, because again, you're knocked out, you get to go home after anesthesia wears off, usually about 30 to 40 minutes after the procedure is done. And usually before the woman leaves the facility, we're able to tell her how many eggs we got, how many eggs were retrieved. And then usually we say the next morning or the next day, we'll let them know how many of those eggs we were able to freeze. Okay. Um, what we do is we kind of take a closer look at the eggs, take time to like clean off the cumulus cells out of the eggs, and we freeze the ones that are mature or close to being mature, because those are the ones that have a good chance that we can work with to get pregnant later on. Immature eggs we don't really freeze because not much, it's not as successful fertilizing immature eggs. Now, that's egg freezing. So again, that's all, that's what this lecture is about. But in case someone's curious, the only difference is like if someone was trying to get pregnant, once we get the eggs, then we fertilize the eggs with the sperm, and we grow it out in culture for about 5 days. And then usually the woman comes back 5 days later. If they choose not to have the embryos tested, then they'll transfer usually one embryo 5 days later into the uterus. And if there's any extra embryos that look good, they don't go to waste. We don't force them in. We can freeze them. All right. That way, if the cycle does not work and they're not pregnant, but they have embryos frozen, they don't have to go through the whole process again that we just described. They can do what's called a frozen embryo transfer cycle. Okay. Or better yet, it works and they do get pregnant and they don't miscarry. They deliver 9 months later, a couple of years down the road, if they were interested in having another child and they have embryos frozen, they can come back, they can use them then. Right. So it's not a guarantee like they'll have that someone will have embryos frozen, but if they do, that's the benefit. Okay. But again, that's for IVF that someone's trying to conceive. But again, with egg freezing, you just freeze the eggs at that time. That way, down the road, whenever it's going to be used, then there's the freedom to use any sperm that they want to use, because if they're not, usually this women are single, that way they don't have a partner yet, they're not committing at that time. You can have options to use later on down the road when the time if they even need it, and if they do need it when the time comes, then you can choose which sperm to use at that time. The harvesting the eggs, this is how we harvest the eggs. Again, it's done under anesthesia. It's done with a probe. It's done transvaginally. You just go through the vaginal fornix, and because the ovaries are right there, so you stick a needle in, and you go into those follicles, remember those black circles I showed you. And I said you can't see the eggs. The eggs are microscopic. What you see is the black. That's the fluid, and what you do is we aspirate the fluid, and in there usually is the egg. If it's a mature egg, they usually come out easily, just like it's like a fruit. It's a ripe fruit. Usually you can pick it off a tree or whatever pretty easily. If they're immature eggs, like smaller follicles, just like an immature fruit on a tree, then they tend to be more tougher to like pick off. Um, so it's the same kind of concept. Again, it's done under anesthesia, taking anywhere from 5 to 20 minutes, depending on how many follicles there are. All right. Then over here is again a schematic. Once we get the eggs out from the ovaries, we retrieve it, we suction, it's basically suction and goes into. I mean, it's not. It goes initially to the test tube, and we get hand out to the embryologist. And then really, it used to be called test tube babies, but it's not really accurate now. We use like petri dishes. But again, egg freezing. Once we get into pipette the tubes, then we put it in storage, and it's frozen. So it's frozen. So when you say it's freezing, the concept, a lot of people think, oh, it's like a freezer. So it's actually it's colder than a freezer. It's like it's in liquid nitrogen, right? So basically, people want to know how long can it last. Really, it can last indefinitely. It's but from a practical standpoint, it's not like someone who usually freezes their eggs or embryos, you know, they usually use it within several years, right? It's rare that someone's going to have frozen and you're going to use it like 20 years later, or 30 years later, or what have you. But it has been done. Right? Again, not often, not because it can't be done. It's just because, like, again, it's not practical. Most couples or most women who have this procedure done, they usually want to have a child, within several years or so. Now, how many eggs can one get? Because the whole issue, the whole concept of here is the more eggs you have, the better our chances. The better chances of having a normal egg resulting in a normal embryo. Okay. So again, like we said before, it's based on egg quantity. And again, we talked about like how do you test for that, how you can get an idea. One is age. That's one variable you can kind of take a look at, get an idea. The younger you are, the better. You can look at the intrafollicular count. Again, that's an ultrasound. When we did, you just count those number of follicles that someone has. The more intrafollicles that are visible, um, then the better the ovarian reserve. And then next to the blood test is the AMH or anti-Müllerian hormone. Again, will also give us an idea how we can expect one to respond to ovarian stimulation. And this is what we talked about. The intrafollicular count, it gets done by ultrasound. Again, the ovarian reserve testing, so again, that's a blood test, that type of Müllerian hormone. So that can be tested anytime during the cycle. This is in contrast before where, I would say maybe 12 to like maybe 15, 20 years ago, we were using FSH, like a day three labs, like cycle day three FSH and estradiol, which again gives us the same information, but it has a lot more variability. The anti-Müllerian hormone is a lot better. It has a stronger correlation to what we're testing for, which is ovarian reserve, which is how one's going to stimulate with medication if they're undergoing any kind of ovarian stimulation. But the biggest advantage is that you can draw it any time in the cycle. So, if a patient comes into the office, they're there, you can draw the blood, you'll get that, you can get that answer from the blood draw from that visit rather than having a patient, if they're not in their second or third day of their cycle, having them come back during that time. And again, it's not intuitive. Somebody tells you what your AMH value is, and you say, was it good or bad? It's not on. Someone says, oh, my AMH is a one. It's not intuitive whether it's good or bad. You know, it, but basically, and say it's one good or bad. And again, it depends. If someone is, 44 years old and someone's an AMH of one, that's pretty good, right? But by the same token, if someone's like 25 years old and their AMH is one, that's not good, right? Because we expect a more active ovary or a better ovarian reserve is someone who's younger, okay? And over time, it goes just lower and lower. Now, how many eggs, people usually want to know, well, how many eggs should I get? What are my chances? So like I said before, the more eggs you get, the better. All right. So you can see in this table over here, roughly on the left side, the more eggs you get, you can see there's a chance of having a baby out of that based on the number of eggs. Over here would depend on the age of when the eggs were removed, right? Because on one end, is right, the more eggs you get, that's quantity, the better our chances. But the egg quality is based on age, right? So if someone gets 10 eggs, oh, is 10 eggs good or bad? It depends. If the 10 eggs come from, say, someone who's 35 years old, say that's roughly about a 50% chance of getting a baby out of that. But the same number of eggs from someone who's like 42 years old, maybe 10% chance. Same number of eggs, right? But it came from a different, the age of the woman. So as a woman's old, gets older, the egg quality decrease. Remember, we talked about the increase in risk for miscarriage, the increase in risk for Down syndrome as woman gets older. That has to do with egg quality. And that's why success rates get lower as woman gets older, the egg quality part of it. All right. Now, the more eggs you get, the better your chances. So if someone's got 20 eggs with 35, yeah, a 10 is about 50%, a 20, maybe a 75%, we get a baby out of that site, out of those 20 eggs. So if someone says like you do a cycle, how many cycles should I do? Or how many eggs are good? And that depends on the individual. So for example, if I have someone who's 35, and the reason why they're freezing their eggs, they said, like, well, I'm single, but I don't want to have a kid. Right now I don't. Philosophically, I don't really, I prefer not to have a kid, but I might change my mind. I don't know. I don't know what the future holds. Maybe I might meet somebody, or maybe me and my partner will, change our minds later on. So I just don't want that option. But right now, I don't think I want a kid. It's just as a backup. So if they get 10 eggs and they have a 50% chance down the road, that may be sufficient for them. They would say, all right, well, 50%, that's pretty good. I mean, I may not even want, but I'm okay with it. Then they're done. They can just, they can leave it. They have their eggs frozen. They go on and go forward. On the other hand, if someone says, hey, look, what, I'm 39, I got 10 eggs, there's a 25% chance that I may have a shot, get one baby out of this. And they may say, you know what, I'm 39. I always envision myself having a family. I really ideally, either I or, my husband and I, or, we really want like, 3 kids, but I'm not ready yet. for one reason or another, either for professional reasons or personal reasons, then they may say, you know what, having 10 eggs with 26% chance, that may be a little bit low. I don't feel as comfortable. So what they can do is they can do another cycle. So they do another cycle, and then they get 20 eggs. Now it's at 45% chance. They may feel more comfortable with that. Okay. So the number of eggs one has, it depends on what their goals are, or what they want to have, what they feel comfortable with. And the way you increase it, obviously, is to do it when you're younger, right? The younger you are, the better your chances are. Now, obviously, you can't turn back time. You don't have a time machine. So what that means is, like, if someone is concerned, is the sooner they do it, the better. Okay, your chances are better when the eggs come out when you're younger, because both the quality is better and you tend to have more. Okay, as you get older, quality decreases and you get less eggs. Okay, so another way to increase it, so well, obviously I can't turn back the time. What some people will do is they'll just do multiple cycles, right? There's no rule at all, so you only have to do one cycle. You do one cycle, you get like 5 eggs. Say, I think that's low. I want to do another cycle. That's fine. Do another cycle. And the thing is, like, what's nice about it, like, you don't have to decide how many cycles you want to do from the get-go. You don't come in, have people come in, they sit down, say, I want to do 3 cycles, Doctor. I said, all right, well, let's do one first, and we go from there. If they do one and they get like, 30 eggs, and I say, oh, I'm actually okay with that, I'm comfortable. Then that's it. They don't have to do it again. Even though they said they want to do 3 in the beginning, you're not going to say, oh, you said you want to do 3, you got to do 2 more. No, you only have to decide the next one, and vice versa. If someone says, like, you know what, I just want to do one cycle. I don't even know if I want to do this. I'm afraid of injections. I just want to do one cycle. You do one cycle, and so you find out, how many eggs you get. Say, oh, you know what, that's a little lower than I would like. The cycle wasn't that bad. I mean, I want to do another cycle, and that's perfectly fine. We're not going to say, now remember, you came in, you say you're only going to do one, therefore you can only do one. No, the only thing you're committing to is the next cycle. All right, so you take it one step at a time. This is another graph, another picture, just showing kind of like what that table showed, basically. It's basically depending on the age, so the different age groups, okay? And you can see like here, the different graphs. Blue is like getting at least one child, red's getting 2 children out of the cohort of eggs frozen. And you can see basically, obviously, the chance of getting one child is a lot higher than getting 3. And you can see when you compare it as you get older, that the chances as you get older, success rates are a lot lower. All right. So the point is here, the way to increase your chance of, having a successful pregnancy down the road for those frozen eggs is the more eggs you have, the better. So you can do multiple cycles. That's one way to do it. And the other factor is the age. So the younger you are, the better your chances. Okay. Let's just do it. All right. I'm gonna see if there's any questions. I'm gonna go. How am I do this? I'm going to I guess I stopped screen sharing. Let's see, stop share. Let me get back to the question box. Let's see. Q&A. Okay, it's Q&A. We're here. We'll go check. All right. So let's go down those here. So how does it work with women who have PCOS and egg freezing? So good question. So it seems like a contradictory, right? PCOS, a woman does not ovulate, right? That's why they usually don't have their cycles, or they have irregular cycles, or they're not ovulating any eggs, right? Or it's less than a regular cycling woman. And you say, oh, well, I'm going to do egg freezing. We want to get eggs out. We're going to see, get the eggs that ovulate. So is it going to be a problem because PCOS has a problem of ovulating? And actually, the opposite is true, meaning like women who have PCOS, they tend to do better with egg freezing or doing IVF in terms of numbers, because the problem with you're not ovulating, we have control in that. When you're on hormones, we can give you what's called a trigger shot to get you to ovulate. So it works exactly the same way in the sense that the protocol is the same in terms of, like, taking the injections, harvesting the eggs. And like I said, they tend to do better because of women with PCOS, remember, it stands for polycystic ovarian syndrome. And the way it got that name, when you do an ultrasound on a woman with PCOS and look at her ovaries, she'll have a lot of those black circles, a lot of those follicles. That's how the name came about, right? So the reason why it's called polycystic, there's a lot of follicles. Whoever named the condition 100 years ago said, "Oh, this condition is marked by an ovary with a lot of follicles, a lot of small cysts." So they call it polycystic ovary, right? But even though they call it polycystic ovary, and there's a lot of cysts in the ovary, the cysts are not bad. These are not the kind of cysts that cause cancer. It's not a kind of cyst that causes pain. It's not bad. It's a description. And again, you're associated with it's more difficult getting pregnant because you're not ovulating. But for IVF, or for ovarian stimulation, with with the gonadotropins or with egg freezing, women with PCOS do better because they have more follicles. And the more follicles you have, the more when you stimulate, the more eggs they will get. Okay. So it works the same way with one PCOS, and actually, from a numbers point of view, it works better. Okay. Um, let's see. How long does the egg freezing last for once you get the procedure done? How long does the egg freezing last for once you get the procedure done? I'm not sure I understand the question. I'll try to answer that question. I'm going to try to guess what. So the procedure basically, again, there are a couple of things, right? So the procedure, the stimulation takes about 2.5 weeks, right? It takes about 10 to 13 days of the stimulation. 2 days later, we harvest the eggs, and that's done from the standpoint of the woman. That's it. Meaning, like, she doesn't have any more treatment. She'll get her period in about 10 to 12 days. So she'll be back to normal in 10 to 12 days. So if you're asking how long is the egg freezing, again, to get the eggs out, usually stimulation about 2 weeks, 2.5 weeks. Now, if the question is like how long, are the eggs frozen, like we said before, they're frozen technically indefinitely. It's in liquid nitrogen, it's an inanimate state, so you can use it, next year, 6 months from now, 5 years from now, 10 years from now, 20 years from now. So that's why, when egg freezing first came about back in 2012, it was officially designated no longer experimental for the cases of women who are undergoing cancer treatment, um, specifically women who are going to undergo chemotherapy. Now, we all know that chemotherapy basically, kills rapidly dividing cells. That's why it's used against cancer. We also know that because of that, it affects fertility. It can make a lot of women like either sterile or it can like shorten their reproductive careers. So, because it kills the eggs, it kills the eggs. So by doing IVF, by doing the egg freezing prior to the woman undergoing chemotherapy, if they have that opportunity, that's where the whole concept lies in. You get the eggs out, they undergo chemotherapy. So again, if the chemotherapy drugs affects the ovaries and affects their ovarian reserve, that down the road, they can use those eggs. So, someone's in their 20s, they can use that later on. But again, going back to the age thing that we talked about, the efficacy of freezing these eggs for say someone who got recently diagnosed with breast cancer, and is undergo egg freezing, um, that the chance for success, the utility is greater the younger the woman is, because you'll tend to get more eggs the younger the woman is compared to someone who's like older. Um, Next one, what genetic testing is typically done during the process? Okay. So the genetic testing that we usually do, specifically genetic carrier screening. Now we do it for IVF. We do it for couples who are trying to conceive. So we do the genetics from both individuals. If you remember from like high school biology, if someone's a carrier for a autosomal recessive disorder, like say cystic fibrosis, and the other part is also a carrier for the same disease, remember that Punnett square, right? If that you make that Punnett square, it's a 1 in 4 chance that both the abnormal genes will be passed on to the son or daughter, and he or she will be affected. All right. So we do that. We screen for close, like, depending on where the genetic testing is done, it could be 300, 400, 600, 700 panel testing for all the diseases. Again, it's only really relevant if both parties are carriers for the same disease. If that's the case, then we have the heads up that if we do an IVF, you can have the embryos tested for that specific disease before we transfer the embryo. Okay. So that genetic testing, if that's what you're referring to, that we do that for couples who are undergoing fertility treatment to conceive. Now, specifically for egg freezing, because the plan is not to conceive right now, and usually the woman is single, we don't do the genetic testing at that point because it doesn't really affect what we do. right? Because it doesn't really matter until the time comes when the woman returns, so it'll be a year later, 2 years later, 5 years later, and she now wants to get pregnant, then that's when we'll do the genetic testing at that time because we can test her and the partner at the same time to kind of decide that. So if that's the genetic testing that we're referring to, like genetic carrier screening for women undergoing egg freezing specifically, it's not necessary. All right, let's see. Uh, that, we did that. What genetic testing data process? We did that. Can the woman implant more than one egg to get twins or triplets? Okay. All right. So this is not an egg freezing question, I presume. Also, just to clarify, so let's step away from egg freezing. Then we'll go into like IVF, and we're trying to conceive, right? We're not just freezing eggs. So now the eggs are fertilized. Remember, when we did the egg freezing, we just took out the eggs, we froze the eggs. Now we're trying to get pregnant in this, I'm presuming from this question, we're not just freezing eggs, we want to conceive. So we get the eggs out, like I said, we freeze the, we fertilize the eggs, we grow down culture, and it depends on how many embryos we're putting back in. Okay. So we were transferring embryos, not eggs, right? We're transferring embryos where they're already fertilized. And the number that we transfer depends. It depends on two things. It depends if the embryos are tested, meaning if they did underwent pre-implantation genetic testing, where we screen the embryos for the karyotype. That way, if they're abnormal, we don't transfer. If they're normal, they're candidates for transfer. If we don't do the testing, if we are transferring the embryos blindly without knowing their karyotype, then the number of embryos we transfer is based on their age. Because again, we talked about these other graphs before, the success is based on the age of the woman who's undergoing the IVF cycle. So if a woman's 37 and under, we only transfer one embryo. If someone's 38 to 40 years old, we would transfer up to two embryos. And if someone's over 40, like 41 and above, we would transfer up to three embryos, again, if they're not tested. The rationale is because as your woman gets older, pregnancy rates go down. So as pregnancy rates go down, you want to be a little more aggressive. So you're transferring more embryos with the hopes that one of the embryos is going to be normal and implant. Okay. Um, Now, by doing that, obviously, a lot of times it's not uncommon that you may have transfer more than one embryo that's normal. And it results in multiples, like twins, and sometimes triplets. That's the case. Again, that's not the goal. We try to avoid that. It's considered a complication, but it's kind of we have to balance it out. On the other hand, we're nowadays where majority of cycles where the embryos are tested, and they're screened for, say, like I said, Down syndrome, Turner syndrome, triploidy. If they're screened, then you only transfer one embryo, no matter what age you are, right? Because remember, the goal before, in the first example I gave, where they're not tested and we're transferring more embryos, let's say someone's like 41, you're transferring three embryos. We do that because we know that pregnancy rates are so much lower. We do that because we know the majority of those embryos are going to be abnormal. So we're kind of trying to say, well, most will be abnormal. Let's increase our chances and transfer more embryos. But with the knowledge and that we understand that the risk of multiples is there. But if you're testing the embryo, then there's no reason to transfer more than one embryo. There's no reason to have risk or take on the risk and the downside from doing so. So if they're tested, we only transfer one embryo. If they're not tested, it's based on age. But the goal is always really to just have a singleton pregnancy. Twins and triplets are higher risk pregnancy. Like I mentioned before, the human species is not really meant to carry more than one pregnancy. That's why there are more complications with multiple pregnancy. Twins, they tend to be born, about a month earlier than on average, between Mother Nature and, current technology and advances in medicine, they tend to do okay. But the risk for delivering 2 months earlier, 3 months earlier is a lot higher. That in a twin gestation, compared to a singleton gestation, the risk for one of the babies dying during the first year of life is about 5 times higher in a twin gestation compared to a singleton gestation. The risk for a severe neurological disorder like cerebral palsy is about 5 times higher in one of the twins compared to singleton. Right? The absolute risk is not high, but relatively to like compared to singleton, it's 5 times higher. But those are severe. Milder forms like special needs in schools a lot more common. Um, but it's not severe. But again, given a choice, the goal for most families is to have a healthy child, a healthy pregnancy, and a healthy mom. And those, the best way to do that is through a singleton pregnancy. Doing more than a singleton pregnancy will put all those at risk. All right. So let's see. Next question. Is AMH typically a false positive in women who have PCOS? If so, what measure? So actually, um, not really. It's not a false positive. It is true that a woman with PCOS will have a higher AMH level than a woman without PCOS, but it's not a false positive. It's actually accurate because we talked about before the way if you look at an ultrasound of a woman with polycystic ovarian ovaries, they're going to have a lot of follicles, right? And because they have a lot of follicles, when they stimulate um, with the gonadotropins, the stimulation medication, you're going to get more. You're going to get more eggs, right? So it correlates. So it's true that the AMH tend to be higher with women in PCOS because they have more follicles. So that is true, but it's not a false positive because it's true. So it's a true positive. Um, so yeah, so the AMH is it says the same thing. It's the same thing if you do an ultrasound. Remember we talked about it's not just the AMH. You can use like the ultrasound to count the follicles, and sure enough, you do the ultrasound in one PCOS, they have a lot more follicles as well. All right, so that's consistent. Okay. Let's see. Um, what coverage or grants are available for women who are on Medicaid? Would these procedures be covered? Okay. Um, so I think Medicaid doesn't cover any fertility coverage in terms of insemination, IVF, egg freezing. Um, so at least as of now, it's not covered. Some insurances will cover fertility coverage, insemination, and IVF. New York State was a mandated IVF state as recently as 2020. Prior to that, it wasn't a mandated state, so insurances could cover IVF, and they don't have to cover IVF, they have to cover anything. But as of 2020, New York State became one of like 15 or 16 states in the country that has an IVF mandate where that they should have IVF coverage. Now, very important, what does that mean? It, does that mean that everybody has coverage? No, because it's a New York State mandate, right? So there are loopholes or ways that we can get around it. So, for example, if the company is less than 100 people, I believe, along with some 100 employees, they don't have to. They're exempt because of the expenses. They don't want to burden a small company, so it's not required. Um, and another exemption is if it's a self-funded policy, so the company itself is paying for their insurance, then that's they have the leeway to do what they want to do with their insurance. So a lot of times, like a lot of religious organizations as well, a lot of unions will provide insurance, but they won't since they're not paid for by the government or not controlled by the government, they're exempt from it as well. And the third main exemption is like if again, since it's a New York State mandate, if your employer is out of state, then they don't have to abide by New York State. All right. So for example, let's say I work in a gas station across the street here in New York. Even though I work in New York and the gas station is in New York, but the headquarters of Mobile, my paycheck comes from, let's say, I don't know where it is, Texas, let's say. And it's not a mandated state, so then it won't be covered. All right. So because of that, it's not 100%. However, since New York State became a mandated state, it's really improved. So prior to like 2020, I would say about 20% of our patients, patient or infertility patients would have IVF coverage. About 80% won't. Since 2020, I think about now it's improved. So I think about like 70%, 65 to 70% of our patients will have IVF coverage. So it's a great advantage to have being in New York State having the mandate, but it's far from perfect because it's not everybody. But having said that, here in the United States, like I said before, about a third of this, because it's a state to state, uh, the states have control of it. So two-thirds of the United States don't have any coverage. It's not mandated, right? So as annoying as it is for some of our patients, sometimes we gotta let's take a look at the big picture where two-thirds of the country, if they want to see a fertility doctor, they got to pay, whether it be insemination, testing, IVF, they have to pay from scratch from the get-go. Um, so now there are grants available. New York State, there's some grants available. It depends if one's eligible or not. So what I encourage you to do is like when you make your appointment to see the doctor, the fertility doctor, then just ask, inquire if because there are different criteria as well. So you gotta see if you're eligible um for certain grants and stuff. Typically, how much does egg freezing cost for the entire gamut of procedures and processing with meds, anesthesia, genetic testing of at least two cycles? All right. Well, I don't know exactly. I'm not a financial counselor. I'm a physician. So a couple of things. I think don't quote me on this. Is egg freezing, I believe, is around $9,000, I think. Uh, again, don't quote me as like the exact cost. But that's just the cost of the site. It does not include meds. The meds depends on how much medication a person uses, right? If someone's a good responder and they only use a little bit of medication, they'll cost differently than someone who's a poor responder and uses a lot of medication. Okay. Um, Genetic testing, like I said before, if someone's just doing egg freezing, we don't do genetic testing. All right. If someone's doing IVF, then that's different. But I think the question over here has to do with egg freezing. So it's egg freezing. We don't do we don't usually do genetic testing. Now it's at least two cycles. So I can't tell you one cycle might be $9,000 plus the cost of meds. So my guess is that if it's two cycles, it's just times two. But like I said, you don't know how many cycles you're going to do yet. You got to do one cycle, and you can decide if another cycle is reasonable or not. Um, again, it's not exact, but prices change. They don't really consult with me. But I think the last I checked, around $9,000 in the base for an egg freezing cycle, which involves the monitoring, the ultrasounds, the blood work, the procedure, and so forth. Can I request my AMH level be tested by blood from my primary care doctor, or is it something that's only testing within this process? It can be tested. You can ask your GYN to have it drawn. Um, but it's important to understand or to interpret what the results are. So I'm guessing from the topic that we're talking about today is AMH. I'm sorry, is egg freezing. Now, a lot of people want to know, like, well, should I do egg freezing? And a lot of people, again, it seems intuitive. They say, oh, it'll be based on my AMH. If I have a good reserve, then maybe I won't. If I have a bad reserve, then maybe I will. Is the initial thing that people think about and talk about. But if you think about it, this doesn't make sense. Okay. If the goal is like, say, I don't want to get pregnant now. I'm not ready. I haven't either met my partner yet, or I'm in the middle of a professional. I want to finish my PhD, or like I'm taking care of my parents. It's not a good time. I want to delay. You know, I'm not ready, but I'm getting older. I want to maximize my chances of getting pregnant later on. We would do the AMH. We would check the the egg quantity, the ovarian reserve. But what I tell people is like that shouldn't make the difference usually, because let's say someone says like it comes back poor, the, they'll say like, oh, it's poor, and I really got to do this. Yeah, you should, because it's just going to get worse. But if it comes back good, I think it's the wrong conclusion to say, oh, it's pretty good, and I won't do it right now. Why not? Are you going to wait till it's no good? Doesn't make sense. Like, If you come back like a year from now or 2 years from now, it's not good. Okay, well now it's not good. Now I'm going to do it now. Why? Because now your chances are lower, and the chances and then the cost is so the cost is going to be the same, or like anything else, prices go up, and maybe even more 2 years from now. And the chances of being successful is going to be lower because one, it's 2 years older, so that quality is lower, and the ovarian reserve, the quantity is lower as well. So yeah, it may have been good now, but 2 years from now it may not be good. So yeah, so to answer your question, you can get it done. You can go to your gynecologist, they can do the testing, but I just caution like what to interpret, what conclusion you make based on that result. And if like most patients, when I first talk to them, I have to explain to them it makes sense. Like, why wait till it's like poor to do it? All right. Actually, ideally, you want to do it to reassure yourself, okay, this is a good chance and this is the time to do this, whatever. Let's go for it. But by the same token, if it's like poor, it's like, oh my gosh, my time is really like short and I really gotta do it. Okay. So yes, to answer your question, it can be done by a primary care doctor. Um, yeah, but again, just be cautious like how you interpret it. Just because it's good, that's a good thing, right? Then we want to maximize your chance for success rather than just waiting and waiting until it's not good. How much does one egg harvesting procedure cost on average? And I think I said like the egg for egg freezing, I believe it's like around $9,000. It could be like 8,800, 9,000, 9,500, something like that. I don't know, but I think close to $9,000. All right. Um, mm, uh, how much does it cost to store the eggs per year? A good question. Um, I don't know. They just changed it recently. They used to be able to pay by the quarter, or pay by the year. I think now it's monthly. So I don't want to give you any wrong information. Um, what was it before? Okay, I'll tell you what it was before. So it's gonna be roughly that, a little more. Um, it used to be, uh, I think it was anywhere from like $600 to $1,000 per year. Um, but that is again that was like around early part of the pandemic. So I don't know what it is now. A lot of stuff has gone up. But when you go through it, when you come in, when you speak with a financial counselor, you'll have all that information available. But good question. If is it better for a woman to free? Oh, hold on a sec. If it is better for a woman to freeze the embryo instead of the egg, if they have a partner. If so, how would the procedure work with the guy and his sperm? Would you collect the egg and then the sperm and combine them via in vivo? Okay, good question. So, um, if it's a choice between freezing eggs and freezing embryos, it's better to freeze the embryo because one, they're further along in their development, and two, most important, those embryos can be tested. You can do what we talked about before. You can do the testing, the pre-implantation genetic testing, where you do an embryo biopsy, um, and that way you'll know if you have. Because one thing to say, hey, I got 20 eggs frozen. All right, so then we have some probably, but we know it's hard to like know exactly what we're gonna have towards the end because out of those 20 eggs, we thought the eggs, let's say 5 years from now, we thought the eggs, out of 20, we get 18. We have 18 eggs, I'm going to try to fertilize them. Maybe 10 of them will fertilize. All right. Of those 10 that fertilize, maybe two or three of them will reach the blastocyst stage as candidates for transfer. You do the biopsy, those two or three embryos, then you probably have like one or two embryos that are good enough for that are, have tested normal genetics and will be candidates for transfer. Right. But each step of the way, there's a variety, right? There's variability. So they said there's 18, but how many fertilized? I say 10. Well, it could be five, it could be 14, it could be 15, right? And how many had developed to like, to the blasting stage? Could be one or two, could be four, could be none. If we're doing embryos, then we'll have a better idea because we're closer to the finish line, right? Because now they're been fertilized. If you do the testing, know if they're normal or not. That way, if someone's really doing fertility preservation, we said there's no embryos that are normal, then that gives them an opportunity to do another cycle before the time comes and they're ready to use it. All right. So that's the advantage of having embryos frozen, right? However, you have to do the embryo to have the embryos frozen, you need to fertilize it with sperm. So it depends on the woman's, where they are in their life, what the conditions are. If they're married, we would say freeze, embryos. You have a husband, most likely you feel confident that, you don't need it now. You want to use it like 2 years from now or 3 years from now, 5 years from now, and you expect to use it with your husband, then we would do that with your partner. If someone's single, you can't use sperm if you don't have a partner unless you use donor sperm. The problem with that is like when you use that, whether you use a sperm from a sperm donor because you're single, or someone has a boyfriend and you utilize that sperm and do the same thing we talked about, and you get good embryos, you can test it. You got to so you have two good quality, two embryos that are tested to be normal in storage. That's great. All right. But let's say 3 years down the road, now you want to use it, but now you're no longer with your partner. Well, you can't use the embryos unless you have the consent of both parties. So it becomes tricky, from that point. So it can be done, if usually if both partners are, they split up and under good conditions and they're amicable, they may be able to do it. They may have some kind of agreement saying, yeah, we're not together, but you can certainly go through with it, but I'm not financially responsible for your child, what have you. Um, so it can be done, but it's a lot more complicated. So if someone is married and they feel confident that they'll be together, then we would say you can freeze embryos. It makes sense. But if someone's single or someone is in a relationship where they're not, it's, they don't know what's going, they're not as confident where they're going to be together years from now when they think they want to use it, then we would say you can freeze eggs. So hopefully, um, I answered that question. I think the only difference is when you're from egg freezing to doing fertilize them. When you get the eggs out, if we're doing egg freezing, we freeze them. If we're not doing egg freezing, when we get the eggs out, then we fertilize the egg, and then 5 days later, or 5 or 6 days later, we'll test the embryos and freeze the embryos. And when we get the results back, then we'll know which embryos are candidate normal or tested normal and candidates for transfer. Um, How much is this process usually without insurance, and how much is it annually to keep the eggs frozen? Yeah, so I kind of try to answer that before. Again, I don't have the exact answer. So I think the egg freezing cycle, like I said, is probably running close to about $9,000 plus or minus. The medications depends on how much medication a person uses. Could be anywhere from like 2,000 to 4,000, 2,000 to $5,000, depending how good they stimulate, whether they do high dose medications or not. And like I said, freezing the eggs annually. Again, usually probably again, don't quote me on this. This is like pre-pandemic. It's about $1,200 to $1,500 per year, I think. All right, so it's roughly around there. Um, does your group also test the male for healthy sperm, or do you refer them to urologists instead? Um, Again, for egg freezing, we don't really get involved in sperm for egg freezing cycles, but if we're doing IVF, so there is a couple that are doing the partner. If the semen, we do a semen analysis. If it's abnormal, we repeat it. We don't make a judgment based on one sample. However, if the repeat semen analysis is abnormal, then we have that patient go see a urologist to get checked out get evaluated to see, what the reason is. Because depending on what the reason is, will dictate what the treatment is. Is it a hormonal problem? Is it a genetic problem? Is it an anatomic problem? Is it, so depending on what the etiology is, there may be ways to improve that. So that would depend on the urological evaluation of the man if it's confirmed to have an abnormal semen analysis. Again, usually we do like two, we require two samples to be abnormal because if you do one sample, it's abnormal, you send it to the urologist, first thing you're going to do is like, well, let's repeat it because it can fluctuate, right? So we usually repeat it. But if it's confirmed to be abnormal, then we have to see the urologist. Is there an age limit on eggs start? Is there an age limit on eggs starting to freeze your eggs? What is a woman is 36 already? What is her success rate? Okay. So again, I showed that graph before. Uh, Point out. Let me share. Okay. So should I share it again? The screen. I do this. Okay. So 36. Am I sharing my screen? One participant can share at a time. Well, um, I think I don't know why I can't share my screen, but again, if you remember that graph I showed, that not graph, not the line graph, but the table rather. So at 36, let's say someone's like 37 years old. All right, so what are these chance for success? It depends on how many eggs they get, right? Because everybody may not get the same number of eggs. So if a 37-year-old got like 10 eggs, all right, her chance for having a baby out of that's about 35%, let's say, or 35 to 40%. So if someone got 20 eggs, whether it be one cycle, they got say they did two cycles, they got 10 and 10, or 15 and 5, or 13 and 7 to end up with 20 eggs, there's about a 65% chance they get a baby out of that. Or if they just did one cycle, and they got 30 and 20 eggs, there's about 65% chance. Or if they did five cycles, they got like, four each time and end up with 20 eggs. Again, it's about 60% chance about getting a child out of that. So the 36 to age determines, basically what the quality roughly is. And as far as the number, it depends on how many eggs you get out. But every individual, may get it's not the same number of eggs that they get. So it has to do with quantity and quality. Okay. Um, so it depends. It depends on what their ovarian reserve is like as well, right? Because a 36-year-old with like five eggs is different than a 36-year-old with 20 eggs. It's different than a 36-year-old with like 40 eggs. Okay. And same thing based on age. So someone who's a 36 with 10 eggs is different than someone who's like 44 years old with 10 eggs, right? Because the quality is different. For the New York State mandate for IVF, that does not include Medicaid coverage at all. Just want to cover the piece. Um, I think for the New York State mandate, I maybe, I'm not 100%, because it gets renewed like every 6 months, every year or so. So I don't know if it's changed, but I think for New York State mandate, someone has to be eligible, you have to have like private insurance that does not cover IVF. And there's a bunch of other parameters. So the only way to know really is to apply for it, is to like, reach out to the center, one of the centers, um, and they'll be able to, you know, look at your clinical criteria, and go from there. Right. Let's see. In case where there's a diminished ovarian reserve, would you guys normally test to determine possible causes prior to egg freezing, or can patient request that? Um, it depends. Um, so for example, if the goal is just to get eggs, to freeze eggs, say, someone, let's say, was recently diagnosed with breast cancer and they're undergo chemotherapy in about a month, and we need to freeze eggs during that time. Then we'll go through the process and we'll freeze eggs during that time. The ovarian reserve being low, it may be obvious. It might be like, patient's like 41 years old. We don't need to do further testing. We kind of know why. Or let's say someone's like 33 years old, but she's had surgery for endometriosis. She had cysts in her ovaries. They had to remove the cysts from the ovaries. We have a reason why the ovarian reserve is low. But let's say we don't have an obvious reason. Someone's like 37 years old and ovarian is a little bit low. We're not going to do testing at that time. I mean, once we know it's poor, as to the reason why, if we have a month to go before we need to like the person undergo chemotherapy, we're just going to get the eggs because the treatment's the same. We're going to stimulate the ovaries aggressively, get the eggs. Why it's low, it's not as big a factor in that time frame. Okay. Now it's a little bit different. Like, if someone's not, there's no time constraint. They weren't recently diagnosed with breast cancer. They don't have to go through chemotherapy. And that's a little bit different. Then it depends on, what the history suggests, how the evaluation is. Again, it may be obvious. It could be, if it's, it could be just their age. It could be previous surgery. Now, sometimes if it's abnormally really premature, if someone's like perimenopausal and they're only like 20 years old, and then you do further testing, further evaluations, you can have a genetic reason for that. Okay. Um, so yeah. Okay. All right. Are there any documents that both parties can sign prior to when it comes to who the own the embryo and who can use it? A woman is single and plans to be a single mother by choice, and she went through sperm donation. Do they give you the vial to complete the fertilization process. Okay, so first, that's two questions. So let's just do one at a time. Documents that both parties can sign prior. Yes. So again, this is not egg freezing, right? Because if it's egg freezing, the woman owns it. The partner, the male partner, has no. There's no argument for them to say that's their egg. It's not theirs, right? It's not their genetics. It only matters if you're doing, they're fertilizing, they're now embryos. Then yes, and usually the couple has to sign something like, what were to happen under certain circumstances. Usually the obvious ones are like if we get separated or divorced, who gets control of the embryos? Or if someone were to, where one of us were to pass away, who gets control of those embryos? Uh, and then so they can designate it so they can have that discussion, and that will be used down the road if there's any kind of like disagreements or what have you. So yes, there is paperwork to under certain circumstances, specifically divorce and separation and death of the other person, what to do with those embryos. Uh, the second question is what? If a woman is single, planning to be a single mother by choice, went through a sperm donation, do they give? Yeah. So if someone is single and they want to, they don't have a partner, they want to use a donor sperm, they obtain donor sperm from a sperm bank. They have it transported here, and we would utilize that sperm to fertilize the eggs and to conceive a pregnancy. So correct. So they can do that. Second, slow here. All right. What motivated and influenced you to get into fertility and REI as a profession? Where do you see fertility going as a field? I feel like fertility is now being taken seriously, but what are some things that patients should advocate for as it relates to speaking to the representatives in Congress? Okay, interesting question. Okay, what motivated and influenced me to go into fertility and REI as a profession? Um, so actually, that's an interesting question. Um, I didn't want to be a doctor initially. When I went to college, I actually went to become an engineer. My parents asked, "Do you want to be a doctor?" I said, "I don't want to be a doctor." I said, "I don't like blood. And I don't like, I just, I like math and science. I'm just going to be an engineer." Um, but when I was in college, like halfway through college, I got sick. I had what was called Guillain-Barré syndrome, which is a neurological disorder. It's a temporary paralysis if it doesn't kill you. Um, so I experienced that. So I was in the ICU for about 6 weeks. Because the concern was that, it's an ascending paralysis that it affects your diaphragm that you can't breathe and respiratory distress and so forth. But you can't move. So, it's, temporary paralyzed, so my muscle wasted away, lost, and I wasn't like, I was, I was a lot thin. I'm not thin now, but a lot thinner then. But I went from like, I think I went from like 125, 130 to like, almost like 105 pounds or what I have. My muscles wasted away. Um, but I got better. And when I returned to school, so I had missed a whole semester, I was an engineer. I decided that, my experience, I felt that the reason why I liked engineering was problem solving. Like the math, the science, you get problem solving, you get variables, plug into, a formula, and get answers out, and solve the problem. So my condition was a neurological disorder. So it's kind of similar like in neurology where, to find out a neurological diagnosis, you get the different variables, whether it be from your physical exam, sensory, blood work, laboratory work, CAT scans, MRIs, you get all this data, variables come in and you kind of plug it in and shoot it out what the answer is, what the diagnosis is, and you have a bunch of treatment. So I thought that was pretty cool. I've gone through it, as a personal thing. So I, went to ask my parents and said, like, I said, I'm thinking I want to look into medicine. Is that okay? Because obviously it would require more schooling, more cost. Um, so they were supportive. Um, so I decided let's give it a shot. I said, let me see first if I can handle being a pre-med, because it's a whole different way of thinking. Like, engineering, it's a bunch of problem solving, it's a little bunch of concepts. You can be smart and some people just pick up, just like that. They don't have to like study this and they look at the problem, they know it. Pre-med is a little bit different. You don't, I mean, it's a lot of memorization. It's not intuitive. There's like whatever 26 bones in the body. If you could be Einstein, and if you don't, study, you're not going to know what his names are, right? So I said, let me see how I do. Let me see if I can handle these courses. And it turned out I was okay with it. So I decided to go to medicine. But when I went into medicine, I thought I was going to be a neurologist. That's what influenced me. But when I was there and went through medical school, I realized neurology is fascinating. It's interesting, but it was kind of depressing. It's like, yeah, you get your diagnosis, you get your, but then the treatments, like, whether it be multiple sclerosis, Parkinson's, stroke, for me, it was kind of like, it was depressing. It was kind of tough. Um, so I said, well, that's kind of depressing. So I wanted more a happier feel. Um, so I thought, OBGYN was kind of like a happy feeling. There's involved surgery, involved, expanding families, like, obstetrics. I thought it was pretty cool. So I decided to go into that. Um, then once I was in there, um, then I realized, what, it's tough. Um, and I wanted to, like, OBGYN was like primary care. So you had to know a little bit about every little thing, because it's not just like delivering babies, it's not just GYN. You have to know like primary care, you have to know high blood pressure, asthma, and it's a lot of knowledge you have to do. You have to know a little bit about everything. And I felt like I'd rather know a lot about something a little bit less, more focused. Um, so I thought that of the different subspecialties in OBGYN, I thought infertility was ideal, because there's a happy feel. You can help again. There's like OB, you can start families. Fertility, help people start families or expand their families, and it was still very, very um, diverse in the sense that you won't get bored. It's not just surgery. There's surgery. There's office procedures. There's seeing patients in the office. So I wouldn't get bored. It would continue to be stimulated, continue to be interesting. Um, so I decided to go into fertility that way. And I thought, I look back now, um, and it's the best decision of my life after picking out my spouse and my wife. That was the best decision in my life. But this is close second. The second part, I feel like fertility is now being taken seriously. What are some things patients should advocate for as it relates to speaking for the website? So yeah, so from a state level, New York State's pretty good. Like I said, from 2020, it took about like 4 or 5, I think 5 years of being put up to a vote in the New York legislature to get mandated coverage for IVF here in the state. I guess the next step is really like, if you think from a national point of view, is really getting like a national coverage. But again, it's based on insurance. That's usually a state by state thing. So, as time goes by, more and more states are getting the coverage, the mandated coverage. I mean, I don't know of any state that kind of who had it and then lost it. But over time, more and more states are adapting to it. Um, my only concern is, I guess, I would say that's what I just said is probably true until it was like maybe like a year ago or 2 years ago, a year and a half ago, um, where there's a sudden turn, I think, like in states like Alabama, um, and Texas, where they're not mandated IVF states, but it became actually, you figure it can't get worse, but it did, because it basically became more restricted. They're holding like fertility offices to a lot of, uh, and I think kind of unreasonable kind of expectations with regards to like embryos and stuff, and embryo storage. So it's making it more difficult for fertility doctors over there, practices over there to provide for their infertility patients. But I'm hoping that it's a short term thing, and eventually common sense will prevail. Because I don't think it's because they're making it political, and I think like when it comes down to it, when it comes down to people, you can be depending on what your political affiliation is. Like I think everybody wants to be able to either start or expand their families if they need help. I don't think it has anything to do with politics. So I think hopefully common sense prevails. Um, so the question is like, what can you do? In New York State, we're ahead of the curve. Um, but I guess again, it's not. Again, like I said, there's still loopholes, but again, it's not. I mean, the loopholes are there for a reason. if you're not in your, if you know your employee's not in your state, then you can't control it, and that's there for a reason. That makes sense. If it's a small company, I understand. You want to financially burden a small company to do that. It's their option to to do so. Um, but the key is, I think, a national thing. Like if it becomes national and you take it away from the hands of the state, then they'll have more power. Um, so I think just talk to your legislature, know where they stand. Again, wherever whatever political thing is, there's always going to be multiple factors that go into it. So those are one of the factors that's important to you that you can kind of focus on when it comes time to either voting or like petitions, that kind of stuff. All right. Although it is mandated, it doesn't cover public health insurance individuals. Will this change for the near future? Um, you know what? I don't know. Um, uh, I'm not I'm not into politics. I'm not involved in that aspect. Um, so I would just be guessing. It would just be like any kind of citizen guessing as what's going to happen. Um, I think the public health it'll take a step from the government, from the national, for example, like government employees, like people work for the IRS, people work where they're getting their insurance like through not through New York State, but from the the government, central government. Um, that's where it's going to come around. Because it's not man, but I heard that they might be changing that. I heard like some government employees are starting to have coverage, so I don't know exactly um, what that is, whether it's at a specific office or if there's a turn in the tide where they might be doing that, but I'm not sure. I'm not sure. Um, okay, let's see. I think is that it? Oh, that's it. Very good. Okay. Um, well, we went through a lot. Went through, the lecture went through a lot of discussion. We did a lot, went through a lot of questions. Hopefully, was able to answer most of your questions to your satisfaction. Like I said, if for some reason, you have any questions, I reach out to your doctor, whatever. Um, we're again, Dr. Pena. I'm just one of like 6 or 7 doctors here in Armory, New York, Long Island. And like I said, we have several offices up and down the island. You don't have to come see me. You have doctors in all different offices. Again, at least Stony Brook, here in Patchogue, West Iceland, Melville's our Melville's our main office. We have an office in Garden City, and we have an office in Lake Success. So just call your office whatever's convenient for you in terms of like where you want to go is fine. If you want to see a specific doctor, you can go see that doctor and then utilize the other offices afterwards. So it's not like you're committed to go to that one office. I have patients who come see me, in a specific office, and afterwards they can monitor in any other office that they want, and vice versa. So, find someone that you're comfortable with, um, and go from there. The key is to get plugged into the system. That way you can answer your questions, especially financial questions. Once you get in, there's a financial counselor that's assigned to you, and they'll be able to try to answer your questions, get your questions answered. So a lot of times it's based on your insurance. What we do is when you call, make an appointment, you get your insurance, you give us your insurance ID and all that kind of stuff, and we verify your insurance. It's not 100%, but we try to get in touch with your insurance and hey, look, what kind of fertility coverage it is. That way, by the time you come in, you kind of know what kind of coverage you have, which is like half the time, that's half the battle. So they can assist you with that. All right. I guess good luck to all of you. If for some reason you have any other questions, just you can go online, go to our website. Feel free to ask questions. And we'll go from there. All right. Later. Have a good evening.